Abortions and miscarriages is a topic of our discussion today, and we will talk about the causes of miscarriages and abortions, the different types of abortions and miscarriages, different diagnostic tests and investigations, and their management.
Abortion or miscarriage is defined as pregnancy loss at less than 24 weeks of gestation. And what is spontaneous abortion? Spontaneous abortion is the miscarriage that occurs in the absence of any medical or surgical intervention. And what is repeated pregnancy loss? It is defined as the pregnancy loss of more than once before the age of viability. So what are the causes of miscarriages? RCOG Guideline about recurrent miscarriages tell us about 8 causes of recurrent miscarriages, and those include, first of all, epidemiological factors, secondly, Antiphospholipid Syndrome, third, genetic factors, fourth, anatomical factors, which include the uterine abnormalities, cervical weaknesses, etc. We have certain endocrine factors, the immune factors, infective agents, and inherited thrombophilic defects. So let us talk about the epidemiological factors, which include, first of all, the maternal age. Advancing maternal age is associated with a decline in both the number and quality of the remaining oocytes. Okay, that's why there is increased risk of miscarriages with advancing maternal age. Secondly, the number of previous miscarriages. The risk of further miscarriage increase after each successive pregnancy loss, reaching approximately 40% after 3 consecutive pregnancy loss, and the prognosis worsens with increasing maternal age. Third is that of cigarette smoking. Maternal cigarette smoking and caffeine consumption have been associated with increased risk of spontaneous miscarriages in a dose-dependent manner. Fourth is that of alcohol consumption. Heavy alcohol consumption is toxic to the embryo and fetus. Even moderate consumption of 5 or more units per week may increase the risk of spontaneous miscarriages. Fifth is that of obesity. Recent retrospective studies have reported that obesity increases the risk of both sporadic and recurrent miscarriages. Now let us discuss the role of antiphospholipid syndrome in causing recurrent miscarriages. Antiphospholipid syndrome is the most important treatable cause of recurrent miscarriages. Antiphospholipid syndrome refers to the association between antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. And the adverse pregnancy outcome or vascular thrombosis is associated with antiphospholipid syndrome. And that adverse pregnancy outcome include, first of all, 3 or more consecutive miscarriages before 10 weeks of gestation, and 1 or more morphologically normal fetal loss after 10 weeks of gestation, and thirdly, 1 or more preterm births before 34 weeks of gestation owing to placental diseases. If you want to study the complete topic of APLS, antiphospholipid syndrome, go to the link in the I button in the top right corner of this video. Now let us discuss the genetic factors. In approximately 2 to 5% of the couples with recurrent miscarriages, one of the partners carries a balanced structural chromosomal anomaly, most commonly a balanced reciprocal or Robertsonian translocation, if the peripheral blood karyotype is performed. Now let us talk about the anatomical factors, which include the congenital uterine abnormalities and cervical weaknesses, etc. So when we talk about the congenital uterine malformations, we have different types of uterine malformations, and the exact contribution that these congenital uterine anomalies make to the recurrent miscarriages remain unclear, since the prevalence and reproductive implications of uterine anomalies in general populations are unknown. But the reported prevalence of uterine anomalies in recurrent miscarriages population range from 1.8 to 37.6%. Now, cervical weakness is a very important cause. It's a recognized cause of the second trimester miscarriages, but the true incidence is unknown, since the diagnosis is essentially the clinical one. Now, what are the roles of endocrine factors in causing the recurrent miscarriages? Systemic maternal endocrine disorders such as the diabetes mellitus and thyroid diseases have been associated with miscarriages. Women with the diabetes who have HbA1c levels in the first trimester are at increased risk of miscarriage and fetal malformations. However, well-controlled diabetes mellitus is not a risk factor for recurrent miscarriage, nor is treated thyroid dysfunction. Now, what are the role of immune factors? There is no clear evidence to support the hypothesis of human leukocyte antigen incompatibility between the couples. The presence of maternal leukocytotoxic antibodies or the absence of maternal blocking antibodies. Hence, they should not be offered routinely in the investigation of couples with recurrent miscarriages. Coming to the natural killer cells, these are found in the peripheral blood and uterine mucosa. Peripheral blood natural killer cells are phenotypically and functionally different from uterine natural killer cells. Now let us discuss the role of infective agents. Any severe infection that leads to bacteremia or viremia can cause sporadic miscarriage. Toxoplasmosis, rubella, cytomegalovirus, herpes, and listeria infection do not fulfill these criteria, and routine TORCH screening should be abundant. So here we have the list of the TORCH infection, which include the toxoplasmosis and other infections, rubella, cytomegalovirus, and herpes simplex virus. We do not routinely do the TORCH testing in case of the recurrent miscarriages diagnosis. Now, coming to the role of bacterial vaginosis, the presence of bacterial vaginosis in the first trimester of pregnancy has been reported as a risk factor for the second trimester miscarriages and preterm delivery, but the evidence for its association with the first trimester miscarriages is inconsistent. Now let us discuss the role of inherited thrombophilia defect. Both inherited and acquired thrombophilia, including activity protein C resistance, most commonly due to factor V latent mutation, and deficiencies of protein C and S and antithrombin 3, hyperhomocystinemia, and prothrombin gene mutations are established causes of systemic thrombosis. In addition, the inherited thrombophilia have been implicated as possible cause of recurrent miscarriages and the late pregnancy complications, with the presumed mechanism being thrombosis of uteroplacental circulation. Basically, we have 7 main types. First is that of biochemical pregnancy. Secondly, pregnancy of unknown location. Third, the threatened miscarriage. Then the missed miscarriage. Then inevitable miscarriage, incomplete miscarriage, and in the end, complete miscarriage. So what is biochemical pregnancy? The patient with biochemical pregnancy have initially positive and then negative urine pregnancy test or serum HCG level. And when we do per speculum examination, we find out the cervical os is closed. Ultrasound is not needed in such case, and no action or no management is needed as the pregnancy resolves itself. Next is the pregnancy of unknown location. So what is the presentation, clinical presentation of the patient with a pregnancy of unknown location? In this type of miscarriage, the pain may or may not be present, and the bleeding may or may not be present. On clinical examination, the os is closed. When we do ultrasound, no intra or extrauterine pregnancy or retained product of conception are identified. And what about action? Beta HCG follow-up is needed and the rescans are needed as appropriate. Coming to the threatened miscarriage. In this type of miscarriage, the vaginal bleeding is there and the pain may or may not be present. When we do the per speculum examination, the os is closed on examination. And on ultrasound, the gestational sac is positive. The yolk sac may or may not be present. The fetal pole is there. The cardiac activity is present in such case. So what action do we need to take in case of threatened miscarriage? We have to reassure the patient, offer rescan if fetal pole is there and cardiac activity is seen, we advise the bed rest and progesterone support. Next comes the missed miscarriage. The clinical presentation of missed miscarriage is that the patient may be asymptomatic. This missed miscarriage may be an incidental finding. Pain may or may not be present. Bleeding may or may not be present. And when we do the per speculum examination, the os is closed. The ultrasound findings are very important in the diagnosis of missed miscarriage. If we find out the gestational sac that should be more than or equal to 25 mm with no fetal pole, or if we find the fetal pole that should be equal or more than 7 mm with no cardiac activity. What action do we need to take in case of missed miscarriage? First of all, we need to explain the diagnosis of missed miscarriage to the patient and explain the different options, which include expectant management, medical, or the surgical managements. We will discuss the management later on in the next video. Let us explain inevitable miscarriage. In this type of miscarriage, the vaginal bleeding is present. Pain may or may not be present. And when we do the per speculum examination, the os is open in inevitable miscarriage. And what are the ultrasound findings? On ultrasound, usually the gestational sac is there. The yolk sac, fetal pole, and cardiac activity may or may not be present. What actions do we need to take? We need to explain the diagnosis of miscarriage and explain the option like expectant, medical, or surgical. Coming to incomplete miscarriage. In this type of miscarriage, the vaginal bleeding is present. Pain may or may not be present. Cervical findings include the open os plus minus the product of conception within the cervix or vagina. On ultrasound, the RPOCs means the retained product of conception are present when ultrasound is done in case of incomplete miscarriage. What action do we need to take? We need to explain the diagnosis of miscarriage to the patient and explain the options like expectant, medical, and surgical. Now coming to the last type, complete miscarriage. In this type of miscarriage, the bleeding is usually settling and the pain may or may not be present. The cervix is closed on examination, and on ultrasound we find intact midline endometrial echo or retained product of conception of less than 15 mm in diameter, and the previous ultrasound evidence of intrauterine pregnancy is usually there. So what action do we need to take place? In such case, we have to reassure and discharge the patient to GP for further follow-up. Ideally, the couple should be seen together at dedicated recurrent miscarriage clinic and given accurate information to facilitate decision making about the future pregnancies. After compiling the accurate information, the next step is the investigation. There are certain diagnostic tests which we will discuss today. If you want to watch more videos about recurrent miscarriages, go to the link in the I button in the top right corner of this video. So what are those specific diagnostic tests for recurrent miscarriages diagnosis? We have antiphospholipid antibodies testing. Secondly, the karyotyping, pelvic ultrasound, thrombophilia screening. So one by one, we will discuss all these tests. Coming to the antiphospholipid antibody syndrome diagnosis, also called APLS. To diagnose APLS, it is mandatory that the woman has two positive tests at least 12 weeks apart of either lupus anticoagulant or anticardiolipin antibodies of IgG or IgM class in a medium or high titer of over 40 gram per liter. And the third one is that of the anti-beta-2 glycoprotein 1 antibody. In the detection of the lupus anticoagulant, the dilute Russell Viper venom time test is done together with a platelet neutralization procedure, and this testing is more sensitive and specific than either the activated partial thromboplastin time test or Cavalin clotting time test. And APLS antibodies are detected using standardized ELISA testing kit. But it's very important to note that the detection of APLS antibodies is subjected to considerable inter-laboratory variations. So we need to correlate our clinical findings along with the laboratory results. Next important diagnostic test is that of the karyotyping. Cytogenetic analysis should be performed on the product of conception of the third and subsequent miscarriages. Secondly, the parental peripheral blood karyotyping of both partners should be performed in the couples with the recurrent miscarriages where a testing of the product of conception reports an unbalanced structural chromosomal abnormality. Next important diagnostic test is that of pelvic ultrasound, which is very important among all these tests. All the women with recurrent first trimester miscarriages and all the women with the one or more second trimester miscarriages should have pelvic ultrasound to assess the uterine anatomy. Uterine anatomy assessment is very important because we have certain uterine anomalies which are very important causes of recurrent miscarriages. So suspected uterine anomalies may require further investigations to confirm the diagnosis using different modalities like hysteroscopy, laparoscopy, or three-dimensional pelvic ultrasound. So after ultrasound, we may move to those testing as well, but the initial diagnostic test is that of the pelvic ultrasound. In the women with recurrent second trimester miscarriages, the cervical length assessment is also a very important tool. And if the cervical length is less than 25 mm, then what we do? We just consider the cervical cerclage insertion. The last testing is that of thrombophilia testing. Women with the second trimester miscarriages should be screened for inherited thrombophilia defect like factor V Leiden, factor II prothrombin gene mutation, and protein S mutation. The management depends upon the cause. And the causes include, first of all, epidemiological factors, secondly, antiphospholipid syndrome, then the genetic factors, anatomical factors like congenital uterine abnormalities and cervical weaknesses, endocrine factors, immune factors, infective agents, and inherited thrombophilic defects. Let us discuss the management of epidemiological factors of miscarriages. The epidemiological factors of miscarriages include, first of all, maternal age, then number of previous miscarriages, cigarette smoking, alcohol consumption, and obesity. Among these factors, the maternal age and number of previous miscarriages are non-modifiable risk factors. Means we don't do anything, we can't do anything with these factors as those are out of our control. But yes, as far as the modifiable risk factors are concerned, we can give appropriate advice to the patient like quitting smoking and quitting alcohol consumption and to follow a healthy lifestyle to reduce the weight. Coming to the management of antiphospholipid antibody syndrome. Pregnant women with antiphospholipid antibody syndrome should be considered for the treatment with low dose aspirin plus heparin to prevent further miscarriage. Neither corticosteroid nor intravenous immunoglobulin therapy improve the live birth rate of a woman with recurrent miscarriages associated with antiphospholipid antibody syndrome compared with the other treatment modalities. How to manage genetic factors? The finding of an abnormal parental karyotypes should be taken seriously, and that prompts a referral to a clinical geneticist who is specialist in the genetic study. Secondly, the genetic counseling has a role. Genetic counseling offers the couple a prognosis for the risk of future pregnancies with an unbalanced chromosome complement and the opportunity for familial chromosome studies. Let us study the role of peri-implantation genetic screening with in vitro fertilization. Its treatment with IVF in women with unexplained recurrent miscarriages doesn't improve the live birth rates. Coming to the management of anatomical factors responsible for miscarriages. Okay, so first of all, the management of congenital uterine malformations. There is insufficient evidence to assess the effects of uterine septum resection in women with the recurrent miscarriages. Coming to the management of cervical weaknesses, first of all, let us study the role of cervical cerclage. Cervical cerclage is associated with potential hazards related to the surgery and the risk of stimulating uterine contraction, and hence should be considered only in the women who are likely to benefit. Second is the role of serial cervical sonographic surveillance. Women with a history of second trimester miscarriage and suspected cervical weaknesses who have not undergone history-indicated cerclage may be offered serial cervical sonographic surveillance. Coming to the role of ultrasound-indicated cerclage. In a woman with singleton pregnancy and a history of 1 second trimester miscarriage attributed to the cervical factors, an ultrasound-indicated cerclage should be offered if cervical length of 25 mm or less is detected by the transvaginal scan before 24 weeks of gestation. Let us discuss the role of endocrine factors. There is insufficient evidence to evaluate the effect of progesterone supplementations in pregnancy to prevent a miscarriage in a woman with recurrent miscarriages. There is insufficient evidence to evaluate the effect of human chorionic gonadotrophin supplementations in pregnancy to prevent a miscarriage in a woman with recurrent miscarriage. The suppression of high luteinizing hormone level among ovulatory women with recurrent miscarriage and polycystic ovaries does not improve the live birth rate. Let us discuss the role of metformin. There is insufficient evidence to evaluate the effect of metformin supplementation in pregnancy to prevent a miscarriage in women with recurrent miscarriages. Let us discuss the role of immunotherapy. We have different types of immunotherapy like paternal cell immunization, secondly, third-party donor leukocytes, trophoblast membrane, and intravenous immunoglobulin. In women with the previous unexplained recurrent miscarriages, this immunotherapy doesn't improve the live birth rate. Let us discuss the role of infective agents. The presence of bacterial vaginosis in the first trimester of pregnancy has been reported as a risk factor for the second trimester miscarriage and preterm delivery. So, for the purpose of its management, consider the use of metronidazole either in tablet form or in the topical form depending upon the clinical presentation. Let us discuss the role of inherited thrombophilic defects, how to manage inherited thrombophilic defects. Role of heparin has been studied in thrombophilia management. There is insufficient evidence to evaluate the effect of heparin in pregnancy to prevent miscarriage in women with recurrent first trimester miscarriage associated with inherited thrombophilia. Heparin therapy during pregnancy may improve the live birth rate of women with a second trimester miscarriage associated with inherited thrombophilias.